Hello and welcome everyone for tonight's EAO Just Ask. Tonight it's a special pleasure and honor because I have a great guest and we have an amazing prosto topic. And I am a periodontist, so I want to learn a lot tonight. Tonight the topic is how do you restore implants in the posterior zone today? And my guest is Professor Petra Gierthmühlen from the University of Düsseldorf. And Petra, before I show your CV, we have some things in common. We spent 1.5 to 2 years in New York together. You were at the Department of Biomaterials. I was at the Department of Implant Dentistry. And we just thought, oh, it's already 20 years ago. With this, a heavenly welcome to tonight's Just Ask, Petra.
So, hello, and I'm very grateful that I can be here, and I'm looking forward to hopefully ask all your questions. And no, I'm very eager and lucky to get started and to start the evening with you.
Perfect. So there are already a lot of guests logging in, coming from Portugal, from Albania, also from Portugal, other people. So they all want to hear your content. And Petra, I don't think I need to introduce you. Everyone knows you from research, from the big congresses. You lectured on every big podium. You just told me you're going to go to New York again to lecture. You started at the University of Freiburg at the prestigious Department of Prosthodontics of Jörg Stroop. Did all your academic things there. Then you went to New York. And now you're the chairperson at the University of Düsseldorf of the Department of Prosthodontics. You lecture worldwide, you do your research in the field of prosthodontics, also veneer preparations and materials. And that's why we look forward to your content tonight. And Petra, I'm a little bit afraid because I brought a case. And as you know, I'm more a surgeon. I'm a little bit doing so a little bit secret. And you know what I did? I placed some implants. And I restored them. I used tie bases. I used different heights of tie bases, as you see it here in the clinical picture. And then I used zirconia, monolithic zirconia, a little bit of cutback in the anterior part, and I screw retained this restoration. So, Petra, just to introduce this evening, what do you think? Was it a good choice? Not so good choice? Should I listen to your presentation or can I go home? What do you think?
I think you already answered all the questions. No, you really did a fantastic job. I like your concept very much. You're using tie bases. This is what we use since a very long time, and it's now proven that it works very well. You're using zirconia. I mean, there's not much materials left other than those to use. And also the concept that you're using regarding the veneering topic is correct. To be honest, I would do the same thing for this case. And now, if you want, I would go through my lecture, and I can only congratulate you on this case because I would have done the same thing. But let us go into the deeper material, and I would like to share with you some slides, just like it's late at night, but maybe you want to listen to my few slides and that I prepared to kind of summarize the concept that we are using at our clinic.
Definitely. We're looking forward. Also, more people logging in from Greece. Also, Team Düsseldorf, they cheering in the chat. So let's go, Petra. We want to hear your content.
So, as you see, this is Düsseldorf in the back, and we're actually having a great spring day today. So it's a blue sky today. And so this is the place where I work. This is our university clinic. And today the lecture is trends and facts of restoring posterior implants. And this is the way that we teach now. It's a lot about digital dentistry. And I would say that the digital workflows, they kind of started a revolution in implant dentistry. And we included all these parts in our dental education concepts. You see, we're implementing printing devices, face scanners, and of course, intraoral scanners. But in dentistry, I think there's not only black and white, there is a lot of gray, and there are many ways how you can solve the cases. But I think one thing is very important. You should not only hope that it work, and I think you should really know the evidence about your decisions. And this is what I would like to show you in my couple of slides that I prepared for you, to give you the evidence behind our treatment concepts. When we talk about restoring posterior implants, it's like such a tremendous topic. It's almost endless to ask all the different questions and to answer them correctly. So I figured I would want to focus on some aspects. So restoration of posterior implants, I would like to focus on all ceramic materials. Just briefly, I will touch some other materials. And I'm only focusing on single crowns and fixed dental prosthesis. So the question that I would like to answer for you is, what are the long-term performance of those restorations? Which materials should we choose? And what are the major keys to success when we restore posterior implants? So let me take you on a journey back to Freiburg at that time. And you see, that was quite some time ago. And this was one of the first cases that we treated this way. And at that time, it was kind of a revolution to solve these cases like this. You see this lady, she was having some posterior molars that had to be extracted. And in Freiburg, ever since we placed implant, when navigation or guided surgery came up, we used it. And for us, it was always important to do everything right, the best way that we could do it. And so we used guided surgery protocols at that time. And then the question always comes up, how should we restore those implants? And at that time, this publication was very common. And to come up either with a restoration, screw retained or cemented, one thing was very important, that the implant position is correct. And that was the key to success for screw retained restorations. Just like a brief overview, what kind of concepts do we have? We have tie bases with you see it on your left-hand side with a titanium base and a zirconia abutment, and then you can cement on this abutment a crown, any kind of crown, or we either use titanium abutment and cement on these restorations, or we use the concept of tie bases and screw retained restoration. I think you will, at the end of the lecture, you see my preference, and I can tell you right now, it's most certainly the screw retained restoration. So this is kind of the first decision that you have to come up with. But then I think it's also important, which material should we use? And I think it's getting tougher every almost year or every day. There is so many materials out there, and every year and every IDS, they're showing new materials that are coming up. And I think for us as dentists, if you're not at a university, it's kind of really too hard to keep track which material can be used for which indication. And there's so many materials out there that I want to focus only in my lecture on two big families. The one is the big zirconia family. I will explain more information on this later on. And I did a lot of research on lithium disilicate. And this is something that is an implant prosthodontics that works very well. And I will show you some of the research that is very important in my eyes to share with you. So when we start looking at materials, I don't want to bore you tonight. It's late at the evening, so it's not a materials science, but I just want to give you a brief overview. When we look at strength, it's very important to know, we know that high strength is more for FTPs and lower strength is then more useful for crowns. And when a new concept is coming up, I first want to test it not in the patient's mouth. I would want to test it in the chewing simulator. And so when the concept came up with the screw retained restorations, we tested those crowns in our chewing simulator. And at that time, we were interested to see how the lithium disilicate, either in CAD or in press, performs, how they will survive in our chewing protocol that was simulating 5 years. We also wanted to know how well does a press crown cemented on a hybrid abutment work. and also zirconia veneered was kind of the control group, but the real control, the kind of gold standard, was the PFM. You can see that almost all crowns survived. I would say the loser in this game was the zirconia veneered restoration. And when we look at the strength, you can see that the strength of the monolithic restorations out of lithium disilicate was superior to all the other groups. And again, the big loser was the zirconia veneered crown. So I think this is very interesting to know. Coming
Petra,
back to
can
our
I
case,
interrupt here for a second because
yes.
I find this so interesting. So allow me to interrupt at any point. I hope this
Anytime,
is fine.
anytime. I get
Um,
enthusiastic and I just can't stop. But
No, no, no. It's so interesting. And this is a very, very good point also for our listeners. And I see that also in my clinical work. I mean, I took over the office of my father and he did implants many, many years ago. And I see so many PFM crowns and I don't see too much chipping. But then I see my old zirconia and veneered crowns and I see a lot of chipping. Why is that the case? Do you think it's different from a bonding of the veneering material to the zirconia when compared to PFM, or is it also something that maybe the metal is also sort of relaxing also a little bit the biting forces? You understand what I mean?
yeah, I mean, this is, I will show some data later on
Hmm.
where we compare zirconia and also lithium disilicate to PFM. I think we always have the feeling that PFM is better. When we go, like, when we look at the literature, we clearly see that there's a lot of chipping with PFM as well.
Okay.
But PFM is really strongly declining in the last year since zirconia came up. But to be honest, PFM has also a lot of issues with chipping. The topping of chipping on zirconia was my topic for, I would say, the last 20 years.
I know.
And I'm kind of happy that I don't talk about it anymore because it's kind of it's like a lot of more interesting topics came up. But the major issue was the thermal incompatibility of the zirconia material is holding the heat for a very long time, and then during cooling there is a lot of tension within the ceramic, and this is one of the major issues why chipping is occurring at that high level in zirconia veneered restoration.
So you think that that the myth that maybe the metal is a little bit sort of relaxing the biting forces, and by this mitigating that, it's a myth, right?
I would say it's a myth, and I will
Yeah,
show you the data later on that PFM has a lot of issues. We're just not looking as critical at these restorations. And when you look at the literature, there's almost no new literature on PFM. Nobody
got
would
it,
like to do research on
got
PFM
it, got it,
anymore.
got it.
So for that reason, we're just looking at the old data, and at that time, it was not like a big issue. But
Yeah.
you will see when I move on in my slides that there is a lot of scientific background also on these
Okay, perfect. Looking forward.
restorations. So coming back to the case, we decided to switch to screw retained restoration in this case, and you see that that was one of the first cases that we did at that time with the Omnicam, and as mentioned before, based on the research that we did, we used the lithium disilicate. You can see this is like nothing spectacular. It's just a simple case that we treated. This is the final outcome with those lithium disilicate chairside fabricated restorations. And this is the lady 10 years later. She's still coming from time to time to Düsseldorf. And I did a full arch treatment in the upper jaw. She was having some erosive problems. And we're also looking, of course, at the implant restoration. You see that's a stable treatment outcome. So when we summarize what we know about lithium disilicate posterior implant restoration, it's a predictable material. It's time efficient when we use it in the chairside mode. It's reliable from a material science perspective, and as you see, it's also an aesthetic outcome. And we know this is just one example of the studies that we are, of course, much more efficient with the chairside or with the scanners in general when compared to conventional workflow. So, what is the long-term performance of these restorations? And so we placed a lot of restorations at that time in Freiburg. And so we started a study. And unfortunately, I can only show you the 1 year data as I moved then to Düsseldorf. And unfortunately, I'm not able to show you any more follow-ups of this study as I left then. And nobody was following up on these cases. So I only have the 1 year data. Now you say, well, everything lasts 1 year, and I fully agree with that. But the colleagues from Munich, they also started a study, and they could show, and I know that Daniel Edelhoff, one of the best prosthodontics that I know, is also placing still a lot of lithium disilicate restoration on implants. And their study also clearly showed that this concept has a high survival rate for A, the implants, but also B, for the crowns. And you see that there are only limited numbers of fractures and almost no biological complications. So also from a biological standpoint, this concept works very well. And it's not only interesting to show single studies, so we all know that consensus conferences are very valuable as they summarize the literature, and not only summarize the literature, they also give guidelines and recommendations for the dentists. And so the base is always a systematic review, and this was a systematic review from the group from mainly Freiburg and some from University of Zurich. And they looked at the 3 year data of posterior restorations. And here, this is the extraction of all the glass ceramic implant crowns. And at 3 year, they could summarize that the survival rate is high at 97%. And right now, we're only looking at the 3 year data. But we also know that a lot of these restorations are in the patient's mouth for a longer time and work very well.
So, Peter, if we can we stay with this for a second? So what would be your decision tree when we compare lithium disilicate and zirconia? I mean, I always have the feeling when I use maybe zirconia, I always think, oh, maybe I should have used lithium disilicate, and vice versa. So what is your decision tree? Are you still saying like zirconia more in the posterior zone, lithium disilicate more in the anterior zone, or what is your take?
I would say that when I show you the data, there's, I would say, no difference in the outcome from a standpoint of longevity. I don't see any difference. My personal preference is still with lithium disilicate. To be honest, it's one of my favorite materials for single unit restoration. It works very well. And with the zirconia, I think we all feel very comfortable as we think that it's a high strength material. But I will show you later on that sometimes we really have to watch out what kind of zirconia are we talking about. And I think this is not really set in all the minds right now. Zirconia is not zirconia. I think this is very important. So for us, I personally, with my patients, I still, I'm a big fan of EMAX or lithium disilicate restorations. We know that there's like a big family that came out. I don't want to open this box, but the only material that has the highest crystal component and less glass is lithium disilicate. All other kind of ceramics out this family, they are having some issues. And so when I use this for posterior restorations, I still use a lot of lithium disilicate. Sometimes
what are your concerns to make it a little bit more clear, maybe also for the beginner who's listening us? Is that also more abrasion on the antagonist? So what is your main concern?
I'm not a big fan to use monolithic zirconia upper and lower jaw.
I
I
got it.
do full arch
But you
restoration.
would do that with lithium disilicate, right?
Yes, yes. I have a
Got
lot
it.
of cases that are now at 15 years and
Got it.
with
Very
no
good point. I think that's a
issue.
very good point.
And I will show you at the very end, I will show you our concept. Well, I think it's not, it's always important to point out the issues, but it's also important to think about solutions for it. And at the end of my slides, maybe give you kind of a light at the end of the
Okay,
horizon
great.
what we could do. Um, but sometimes also the dental technicians, they're kind of pushing you when you have, for example, an FTP and you have an implant crown next to it. They say, "Oh, I don't want to have a lithium disilicate next to
Mhm.
zirconia. So why don't you use zirconia like full arch?" And so sometimes these kind of discussions come up. But I can give all the dentists only the advice. Well, I think it's important to kind of find a solution together with your dental technician, and it's possible to do both, also neighboring. I
Okay,
just sometimes don't like it, but
I
they
got
can
it.
do it. And I think in many cases, still glass ceramics make a lot of sense, and
Okay.
I'm a big fan of it still.
I hear that.
So when we
Okay.
look at trends,
Yeah.
zirconia is getting more and more popular. We know that. And this is what I was just talking about is that zirconia is not zirconia. There are a lot of generations, new generations that came up. I don't want to go too much into detail. I don't want to bore you tonight. But I think it's important that when you move up in translucency, we know that the first generation, it was just brittle white and it was not aesthetic at all. So for that reason, everybody tried to put more translucency into the game, but it always comes at a price. And at this case, the price is the strength. So the higher the translucency, the lower is the strength. And many of those materials, they come like in a sandwich configuration. So the sandwich has many components. One kind of the sandwich concept is that you have a color gradient, but a lot of the new materials, they have a strength gradient. So they have different materials that are composed in one blank, and those materials have different strength, which you can see here. And I think this is always important to know. And the dental technician, and now a lot of software issues and artificial AI tools are kind of placing those restorations correctly in those blanks to get the ideal mechanical but also aesthetical outcome of the restoration. So when we look at monolithic zirconia restoration, this is just a very simple case that we did with our students. So it's daily life in our clinic where they place those restorations. It's nothing spectacular. You see, it's a chairside workflow. This is a case from Frank Spitznagel, and he was placing the implant, and then also used scanner and then finalized the case with a zirconia crown here. And when we look at the data, and we can see that when we look at digital workflows compared to conventional workflows, we can save a lot of time. And we could also see, or in this study, they could show that also the time for adjustment is much lower when you use digital devices. And when you look at the survival rates, it's 1 year. I mean, it doesn't say much, but it's just a trend. It shows clearly that those restorations, monolithic restorations, work well. This is a very recent study that just came out, and they also looked at conventional and digital workflows. They could also show that both workflows work very well. What was very interesting to see is that they perform the same. And what was also interesting is that the patient only had one preference regarding recommendation. all the patients that were treated with the digital workflow recommended this to their friends, and this was kind of the only difference that was could be proven in this study. But when we look at the outcome of the restoration, it was very positive. You see only this one picture. There was only one fracture of a thigh base. In my clinical experience, it's very, very rare. To be honest, I've never seen one, and I see a lot of cases in my clinic. There were two decimentations, but I will come to this point later on. So this was your question. How is monolithic zirconia compared to other materials? And I think this is very interesting to see, as we all feel that metal ceramic was the gold standard for a very long time. And so this systematic review addressed this question. What is the comparison of metal ceramic versus monolithic zirconia restorations? They only looked at the 1-year follow-up, as not so many studies are out there right now. And here you can see it. It's very interesting. You see the MC as metal ceramic, and like survival rate wise, they're at the same level. Like also a lot of other factors, they are at the same level. But there's one very important thing to notice, that metal ceramic actually has a lot of chipping in implant prosthodontics, and you see that the number of percentage is a lot higher than in monolithic zirconia. So I think this is very interesting to realize that there was no difference in survival, failure, bleeding on probing, bone loss. But monolithic zirconia appears to be more reliable than metal ceramic restoration. I think this is very interesting to realize, as we all think that metal ceramic was the gold standard for a very long time. So when we now want to compare zirconia versus lithium disilicate, we see that there is no difference, at least at 3 years. Unfortunately, there are not too many studies that have a longer observation period, but if you ask me, I don't expect that there are like survival-wise differences. I think there may be some other differences over time, but not in the survival. So the big question is always, and when I lecture, I always ask, do you veneer restorations, yes or no? And I'm always surprised how many dentists still do veneered zirconia restorations. And to be honest, I don't really understand why. I just think of course, in the anterior zone, it's important. There you need it. So you need the concept of microveneering. But for me, there is no reason at all to put any veneer on posterior restoration, either in teeth or an implant. But on teeth, maybe, but I can't recall when I placed the last veneered restoration. I really can't recall, but I would never do it on an implant. This is my personal opinion, but it's not about personal opinion tonight. It's about scientific evidence, and this is what I'm trying to show you now with this consensus conference overview. This systematic review looked at this comparison, exactly at this comparison, and so here is the summary. They looked at different studies, extracted all the data, and this is the outcome. And here you can see it clearly. You see the survival rate is at the same level, but the complication rate is much higher when you look at veneered restoration. And also the chipping rate, of course, is increased when compared to monolithic restorations. So again, in the posterior, monolithic restorations should be placed. Of course, we know in the anterior we need microlayering and zirconia and buccal veneering on these restorations. And like just recently in Germany, this Leitlinie guideline came out, and also they had a lot of recommendations. They were also published in English. And they also put the recommendation that monolithic restoration should be or shall be preferred over fully veneered implant restorations to minimize the risk of chipping. I think this is a very clear message that I would like to place. So now we have kind of the topic of monolithic versus veneered. When we now move on, screw retained versus cemented, I think this is also something that is discussed extensively over the last years. We all know that with cementations, we have a lot of problems with residual cement. And so many studies try to eliminate this problem, and you see that all kinds of concepts were shown. But to make a long story short, none of these attempts were really successful, and no method. You see, they used rubber dam and cord and whatever, but none of these methods was able to bring the residual cement down to zero. You see that there is still a lot of cement left, and we know the complication that are coming from these residual cements. And I think this study is even more clear. It's quite a recent study, and I think it's really horrible to see how much cement is still sitting down there. And so they were quantifying the amount of residual cement. And what was very interesting, I mean, it's quite obvious, but it's very interesting to see it in a quantification, is that when you move down to the subgingival margins, when you have cementation margins, it's kind of impossible to get rid of the cementation to this of the residual cement. And you see at the level of 60%, you have still cement there. And obviously, it seems to be very complicated in the mesial part to remove the cement here.
So, and Petra, just let me interrupt you for a second. And we're talking about individualized abutments in these cases, right?
Yes.
These are not like stock abutments, because I hear a lot of people saying, yeah, in stock abutments it's clear. But if I use a perfect individual abutments, I can clean anything. That doesn't seem to be the case, right?
This is what we all feel, and I think it's always interesting to say, to hear when people see, I feel I did a good job, and we feel that we did a proper cleaning process, but we're just, I think everybody is trying to work hard and to work at the highest level, but you're just not able to clean this. I think there is just no way that you successfully can clean off these residual cement. And I think the study is so interesting to see how we're not successful in placing those restorations. And so I think it's pretty obvious that we should avoid, when we see this study, that we should avoid cementation whenever it's possible. And this is also one of the statements that I would like to give you tonight, that whenever you're able to screw retain a restoration, you should go for it, and don't cement, because you're not able to clean it properly.
Good point. Yeah.
So I think it's important to know. So the tie-base concept came up many years ago, and they're prefabricated, and they come in different heights. And you were mentioning this before. We know that this is very important to select the correct height. And I think it will be very interesting in the future, or in the near future, how much AI tools will actually guide us here in these kind of selection of components and everything. I think this is something that will be starting soon and will facilitate our daily life. I think this is very important. And this is one thing, so you should select, or together with your dental technician, select the correct height. We all know that.
Petra, can we stay with this for a second? Because I think it's such an important point. I, as a periodontist, would say this is, for me, one of the most important points. Give us very briefly your concept. I mean, how do you select the height of your tie base? It obviously depends on what kind of implant you use, bone level implant, tissue level, hybrid implant, whatever. But I think this would be a very, very important information if you give us a very short idea of how you select the height of the tie base.
So you always want to give the tissue some space to to develop, and you want to have it narrow and
Slim.
slim. And I think it's strongly depends on the depth of the placement of the implant. This is very important, and we all know that there is kind of the magic 2 millimeters that the mucosa needs, and you always want to be stay away from the crestal bone. As we know, this is for the peri-implant health very important to have a certain space to be stable over time. So I think it's also in the very
Yeah.
nice review by Munoz. I'm not sure if I pronounced the name correctly. Displayed nicely that those 2 millimeter is very important for the long-term success. So this is what we always try to attempt. This is kind of the height when we look at the mucosal level, but also the pros height is important.
Right.
I think here it's kind of a more mechanical issue. We know that it should be kind of parallel, and we need a certain retention surface for a stable bonding surface over time. I think then it's kind of more a biomechanical issue what we need. And you see here also the angulated tie bases. I think here it's also very interesting to see. We always know. I'll show you some clinical studies on this topic in a few seconds. That the wall height is important also for the longevity of the crown. So
Got it.
yeah, it's kind of a balance between many factors, and I'm very eager to see what. Right now, I think it's still a lot of what we have as experience.
Maybe very briefly, what do you say about these concepts where they say, I always use the smallest tie base available, could be a millimeter, and I immediately start with highly polished zirconia, even subcrestal, because zirconia is the best you can do to any tissue. What do you say about this? You get my point? I mean,
Yeah, I mean, you're the periodontist. What do you think?
I
What's your
I
opinion?
think the concept of getting out of the bone to getting the height of the tie base according to the situation where you have the emergence profile, at least out of the bone, is the better concept, because you will always have a gluing gap also. You never know what's going to happen in this gluing area between the zirconia and the tie base. So I would always advocate to choose, as you said, the height of the tie base according to the height of the tissue. At least try to get out of the bone with the tie base and the height, right? That's what I would say.
Yeah, yeah.
Good point. Good. Okay.
So this is just you can shorten them, and that's individualized. And when you first when I was first showing those cases with the tie bases, everybody, and depending on the region, many people approached me, especially during coughing break. I said, "Oh, you know what? I have a lot of decementations of my tie base and restorations." And so it was obviously a big issue, and some of the manufacturers came up with laser treated, I'm sorry for the German here, with laser treated surface to increase the bonding capacity of the restoration material to the tie base. And they were using alumina abrasion before, but this concept is obviously made to increase the bonding strength. To be honest, we never had issues with that, never. So to my eyes, it's more like a problem with the bonding protocols. But when you stick to the correct bonding protocols, we never had issues. When we talk about implantology, everybody has a bad day from time to time. But when you talk about bad days in implantology, you sometimes just miss the target. And I assume this person really had a bad day. I think this is quite a malpositioned implant. And this lady was actually referred to my clinic. And she was having this implant and she was having cemented restoration on this implant. And this restoration was coming off like on a routinely base. And she was very unhappy with the situation, so she went back to her dentist, and the person referred her to the clinic and said, "Well, I'm not able to restore this implant anymore. Can you please place a conventional FDP on those neighboring teeth?" And I said, "Well, I will not do this. I'm a prosthodontist, but I will never put a conventional FDP on those two healthy teeth." So we figured a way out to kind of overcome this, I would say, suboptimal situation. So we came up with this screw retained restoration from zirconia. We discussed it with the lady, and she said, "Well, it's like more like a long-term provisional." I would say that's a long-term provisional. It's not like a permanent crown. It's from the fabrication. It's a permanent material. It's permanent cementation. It's a permanent crown. But we said maybe it's like more like a provisional. So we finalized the case. You see, it's not ideal. We're not able to come out other than this, but we were able to restore this implant and it's still in place, and she's happy. So sometimes we have to be creative to kind of come up with a solution. I was showing those angulated abutments, tie bases before, and I think it's a very interesting concept. And I mentioned before how much problems we're expecting with cementation. So I think with those angulated tie bases, we have a very nice way to overcome this problem, the cementation problem. And we see when we look at this survival, we see that at 3 years, those restorations and also the implants are doing quite well with 96%. We have no biological complications, no restoration fractures, and only 2 screw loosenings here. And this is a very a recent study, and also with a longer observation period. They also looked at those angulated abutments and zirconia restoration on top. And they also looked at different parameters at the 5-year follow-up. And they showed that the implant survival was high, the pros survival was high, but they reported some technical complications, such as 1 fracture of a restoration. This is why the restoration survival is at 97%. Quite some screw loosening with 9 screw loosening, and some of the screw excess restorations were lost. But biological issues were not observed in this study, and also the patients were very satisfied with it. So in conclusion, those angulated tie bases are very suitable, and they show low biological complications. The patients are satisfied, and those technical complications that I mentioned are quite easy to handle. And so in conclusion, this is, I think, a very reliable treatment concept that we should consider. So when we look at other trends and facts, I think this is also something that Frank, who places a lot of implants in my departments, he likes to use this concept, the socket seal concept. It's much easier for us to come up with a nice dimensional stability, and also hard, soft, and tissue dimensional stability, while decreasing the overall treatment time. I think it's a very nice concept that was introduced and now is kind of modified to prefabricated abutments, where we kind of have a 2-in-1 solution. So it is an abutment, but at the same time also a skin body. So I think it's a very nice device, is facilitating the scanning and also is stabilizing the tissue after extraction. We have less visits for our patients, and we only have 1 component that you need. It comes for all indications, posterior, also anterior, also premolar indications. And I would like to show you just one case that Frank did. And there you can see that he placed this abutment and obtained a very nice soft tissue contour here. And so the dental technician was able to just work on this scan and could like match it and just design from that the restoration. You see that he kind of just had a minor modification in the buccal part, and then he was able to finalize this restoration. So it's helping us a lot to obtain a nice soft tissue outcome here. And those are, again, cemented monolithic restorations here on these implants. And again, it's just a very not easy, not spectacular case that we did. So now I think we're almost done with the topic of single crowns. So we move on to FTPs. And when we look here at the impact of digital workflows, this is a study from Switzerland. So you can see again that those digital workflows tremendously increased our efficiency. It's not only time, it's also cost efficiency that you can see here. And also when we look at the modification time, it's more precise and results in a higher treatment outcome when you use the digital workflows. And the survival rates here are only at 1 year, so it's quite still not too much literature out here on those restorations. So again, the ITI was looking at monolithic and veneered FTP restorations. And again, they were looking at veneered and veneered zirconia and monolithic zirconia restorations. And you can see that the number of chippings, again, was at a higher level when you looked at veneered restoration. And also the size of the chipping was more extensive with the veneered restoration when compared to monolithic restoration. So, and also when compared to PFM, again, the monolithic zirconia was superior to PFM, so it's the same picture as we had in the single crowns. And one thing that I think is important to address is that we don't have scientific evidence on all this new generation of zirconia materials. And for this lecture, again, I was searching a lot, but I couldn't find a study that was long-term, more than a case series on these novel generations of zirconia materials. So here, just one case from our clinic. So this is how the lady came, and then we placed implants. So in the anterior zone, we of course need, as mentioned before, the buccal concept of buccal veneering, microveneering, and all the function is still in zirconia and also in the posterior. So we have the function in zirconia, but the aesthetics with the buccal veneer. We only places for the premolars. I think there's not much reason to use this also in the buccal part of molars. I think there's just no need to perform this. Very important, all the patients, they receive a splint to protect these restorations. And I think this is very, very important. So when you buy a nice car, you don't put it in the street. You put it in your garage, and this is your garage for the restoration. So again, coming back to the summary and the recommendations also from the guidelines from Germany, we have learned that zirconia is actually the only material that can be used for FTP. So I think this is pretty obvious when we look at all ceramic materials. We want to avoid the veneering whatever possible. As mentioned, we need for the tie bases sufficient height and sufficient retention surfaces. And when cemented, we should use individualized titanium or hybrid abutment. And I think it's also important to point out that we don't use zirconia abutments underneath the restorations in the posterior. We always use titanium, and I think this is very important. So, but again, we only have evidence right now on the classical zirconia, so the zirconia with the high strength. For the other generations, we just have no clear clinical evidence that is available. So this was kind of the data on FDPs. Now I would like to provide you some, I think, very important keys to success. One is you should use, in my eyes or in my clinic, we're only using original components. We had one case where we always write it on, we're still not as much, we're digital in our treatment, but not like when it comes to communication. It's the university, so we still use a lot of paper and fax, and this is sometimes a little bit old-fashioned. We once had a case when we sent it off, we said original parts, but they didn't use an original part, and they had to redo the case because I lose my warranty for the implants. And when we look at this very nice review, I'm just inviting you to read this review. It's a very nice summary. It's pointing out all the problems that you are facing. You are saving money, but it comes at a high price in my eyes. You have compatibility problems, you have differences on a microscopical level, lower position, compromised stability, and a lot of problems like fracture and so on. And it doesn't really seal properly. So I think this is something, the lower price of the components result in an increased complication rate. So in my clinic, I don't want these kind of problems. And one other thing that is also very important, you have to inform your patients comprehensively. And I think this is a very nice study from the University of Zurich. They were looking at all their cases over time, and they realized, and I think you also, when you look in your at your patients, you have realized a lot of restorations where you have the same problems, that you lose the contact between implants and natural teeth. And I was shocked when I saw the study that is at 50% of the cases. And in their study, they also point out that on FTP, the problem is worse when compared to single crowns. And also that the probing depth is increased. I think this is something that is very important, and we are mentioning that when we place implant, that this is one of the possible complication. Why does it occur? We're having tooth migration. This is natural and physiological over time. We still have ongoing growth, and sometimes you have to replace either place a composite when there is some food impaction or when the patient is not happy with the restoration anymore. And one other very important issue is also identify bruxers. And also this review is very interesting to see. On implants, it's even worse. You have a higher, I mean, bruxers, they kill any restorations. We know that, not only on the teeth, but I think on implants, it's even worse to the reasons that are mentioned here. They have higher loads, excessive overload. And so they're really at a higher risk level. And this is something that we should always keep in mind. I think we have to point out these issues in your informed consents. And also all these all these patients receive a splint for the night. And we also have to check if what the manufacturer's indications are of each materials. And also we have to discuss this with our dental technicians. And so this is just one case of a lady. She's a heavy bruxer, and this is before the treatment. And you might think we're back to the 80s, but it's not. It's a very recent case. We're still using metal occlusion. You see in this case, even gold occlusion, I think right now with the gold price, but I heard it's declining. It's quite tough, but we're still, I love all ceramics, but I still also do these kind of restorations. I think we should always find the right indication. You shouldn't I personally prefer gold as it's not as hard as all the other metals, but I mean, it's quite tough to afford. But this is also something, I mean, young patients, they would never like these kind of restorations, but still think about it. This is a treatment option. We don't do it often, but it's still out there and it still can be used. So I'm almost done. I'm kind of at the end of my presentations. When I look again, when we look at single crowns, I could show you that we can use lithium disilicate and monolithic zirconia. At FTPs, we're only down to monolithic zirconia, and this is also a very nice review that I would like to invite you to read. It's a very nice summary, and this it's very concise, this guideline. If you don't want to read too much, I think this is very nice as a conclusion to read. And when we look at the road ahead, what will the future bring, or what are current trends? I think AI is a big revolution that is everywhere, and I think it will also affect us a lot and help us a lot. And I think the first AI-based designing tools are out there, and when we compare how well they perform, when the gold standard is still our dental technicians, we see that they're doing an amazing job. And I think what you read now is tomorrow already old-fashioned. I think there is a tremendous evolution in this topic in AI, and this study could show that those AI-generated implant single crowns are very close to the dental technician. I think this is very interesting, and I think we shouldn't be afraid. I think it's a nice addition for our dental technicians. They will help our dental technicians, but we still need them, so they will not replace them. I think they will work kind of hand in hand, those AI tools, and I don't know how it is around the world, but in Germany we're having issues finding dental technicians. I'm blessed to work with a lot of very skilled dental technicians, but in general, it's quite hard. And I think hopefully AI will help us here. We all like to print a lot, and also we're printing restorations, just like a small example here. And I was at this conference 3 years ago, and at the ITI, and at that time the summary was that there's only limited data out there. I think it's 3 years ago. I think we move on, and when you now look into the literature, there's a lot of literature coming out, quite limited. We are now looking at two-year data of this study. They're looking at printed restorations here. You see this case here. And when they look at the clinical data, it's promising short-term data. So I think it's a very interesting tool in fabricating restorations. And kind of jumping back to zirconia, I think zirconia material, and you were mentioning why do you like still lithium disilicate. Zirconia has some downsides in my eyes. I think we need a new concept or other concepts when we look at zirconia against zirconia. And I would like to share this case. This is a quite young lady. She was edentulous in the upper jaw. We placed implants in the upper jaw, restored her with a full arch monolithic zirconia restoration. And you see she was edentulous, placed zirconia veneers, posterior implants, and everything in monolithic zirconia. Nice treatment outcome. But I'm not sure if you ever kind of paid attention of the sound of zirconia against zirconia. It's not like the nicest sound. I'm not about sounds, but we also have to keep in our minds that 85% of the prosthetic complications occur when we have implants in the opposing jaw. So implants are really putting our pros restorations at a high risk. And so this is something that we always have to keep in our minds. So maybe it's kind of wise to combine different materials. When we have softer materials that we can combine with the stability of zirconia materials. You see, this is just one example. We all know that those restorations have other downsides. I wouldn't say that this is the perfect material, but we had two theses on this topic, and we looked at crowns and implant crowns and also at FDPs. Sorry for the German here. And we used the zirconia core and put the softer material as an antagonist. On top, we did an adhesive bonding, and we could obtain quite reliable results here in an in vitro setting. My dream is that we're using not this kind of bilayer concept. So my dream is that we're facilitating printing. I very like the Midas concept, where it's just as easy as an espresso coffee machine. You just put this capsule and you get not your coffee, but your restoration. I think it should be that easy. And my dream is that we have kind of a gradient multi-material material that is printed. I think this would be very interesting concept in the future. So hopefully I was able to show you different ways to restore implants, and it's not always black and white. There is a lot of gray. And I think dentistry is always teamwork. This is the team that I work with. And now I'm very interested and happy to answer your question and to see what you would like to ask me and what you would like to discuss.
Petra, that was amazing. I mean, congratulations to your work. Congratulations to your team, to your presentation. I loved it. I learned so much, even as a periodontist. So chapeau, amazing. People applaud you. Petra, we are a little bit at the end of our time already, but I want to at least push you some of these questions. I think one question is important, and you alluded to that. Stadius wants to know, what is the torque for the angulated abutments? Does he need to minimize the torque compared to a straight one?
I mean, you always have to see what kind of, there's a lot of difference. So in my department, we have like a spreadsheet with the torque of each system. And I think this is very important for each system. The torque is different. So you will have to check what kind of angulated restoration or base you're using, and put it on your spreadsheet. I have it in my drawer, and each time I place those restoration, I look at that, and also my coworkers have to do that, because you really want to avoid that.
So pretty much stick to the manufacturer's recommendation.
Right.
There's a question about healing abutments. I mean, you talked about the socket sealing. Is that also possible to do that 3D printed? Like now you have in the stock sealers like premolars, molars, but could that also be a 3D printed individual healing abutment?
Of course.
Is that also possible?
Yeah, what we do, or Frank does a lot, is that you kind of order it when you order your or fabricate yourself the splint for the implant placement, that you design it right away when you do it together with your dental technician, that you order it, that it's kind of based on the digital planning. You prepare it before, and when you have your surgery, you have it already prefabricated by your dental technician. And you can either mill it, you can either scan it during your surgery and then get it milled. You can also print it. I think with the printing, there's still some things still open when we look at surface roughness and also biocompatibility things. I think there are some questions still, in my eyes, not answered, but you can also print it. Yeah.
There's one question which I also find very interesting, and I'm looking forward to your answer. It comes from Sven Mühlemann. Hi, Sven. Great that you're also listening, and also from Stergios. They're both alluding a little bit to the problem of what do I do when I have a splinted restoration? Could be a bridge, or it could also be two splinted restoration. How do I do that with the internal connection part of the implant? I mean, Sturgis is asking, they can never be so parallel that I can use the engaged parts. And Sven is a little bit more alluding to, should I use a multi-unit abutment configuration, or should I one part which is engaging and one part is which is not engaging? I think this is a very interesting question.
So what we do a lot is one part engaging, one part not engaging.
Mhm.
But to be honest, there is no scientific data out there on this topic.
But
I
what do
think
you think there will be, like, if I do both engaging parts and I will bring that in, will there be tension? Definitely, right?
yes, yes, I would say yes. I would say yes. In most cases, we're using the concept of kind of mixed, as
Yeah.
was mentioned um, before. But I think also I was trying because I was kind of expecting these kind of questions. I was trying to figure out if there's research out there, but it's not. And I think it's a very important thing that we still have a lot of. Steps in our pros workflow that we just do, but we don't know
Yeah.
which way is the better way. And
No,
there's,
no, I do the same. I do the same. But I think, what do you think about Sven's idea of you using a multi-unit abutment and then working on the multi-unit? I mean, you have a third part now, right?
yeah, I mean, we were using that also at the time when I was in Freiburg. Um, to be honest, these kind of questions, I always ask my dental technician what he likes most, because I think it's always important. I mean, together we kind of try to develop concepts together, but some dental technicians, they like to do it this way. Some use the mix procedure, some are more into
Yeah.
multi-unit. And so I
Yeah,
think,
with a multi-unit concept, I always have the feeling, particularly if you work in the perio patient, you give away a lot of like engaging room for your
yeah,
screw and everything, right? So
yeah,
I find this concept also good to use the non-engaging part when an
yeah,
engaging
yeah.
part. A great question, Sven. Good that you're listening. There is a nice question, maybe with a short answer. Can I cantilever monolithic zirconia, and how many parts can I cantilever?
That's a good question.
Not a short
There's
answer.
no robust scientific answer that I can give. To be honest, I'm not feeling comfortable with that. We're not there are like not many cases that I have in my
Not
department.
even in a like all on four case or something like this, you wouldn't cantilever?
I mean, there are rules like the 8 millimeters max
Mhm.
of cantilever. This is what we know. I think it's feasible.
Mm.
I'm just never sure when it would come down to a lawsuit, what I would do,
Okay.
because there's just like no evidence that
Yeah, yeah.
count on. I mean, there's a lot of data from Moskowitz, and they say it's not an issue. And Hakuzo, they did a lot of some studies, but I think scientific wise, it's not. There is no answer.
There's one question which goes a little bit more to the periodontist, but I'm looking forward to your answer. So is lithium disilicate also as gum friendly like zirconia? What do you think? What does the prosthodontist say?
I mean, we're when you look at the when we look at posterior, I think I would say yes. When we look in the interior, we of course still use the concept of zirconia when we have to cement restorations. We
Yeah.
have done a combination of both, and when we have like long abutments. I would prefer zirconia and
Would you
but
say,
the
Peter, just
posterior.
to grab a little bit deeper, is that a matter of material, or I sometimes have the feeling, and I also think there's a little bit of research on that, that it is more the polishing ability of these materials which make it gum friendly, let's call it like this.
Um, yeah, I agree, and I think mm, I would say that the zirconia can be polished at a higher level
That's also
than
my feeling.
lithium disilicate just kind of feels the crystals. And I was just like inserting restorations today, and I had to adjust it in the proximal parts, and I was polishing. But
Yeah.
it comes to a certain point, but then it's like it just can't get more. Yeah.
So, Petra, this might be an argument for zirconia in the future in the University of Düsseldorf. Huh? What do you think?
No,
Uh,
I mean I think we have a good mixture of both.
no, I'm kidding. Wonderful. It's so nice to talk to you. There's just one more comment. Maybe we should look into this. There seems to be a published data in JOMI 2019's for both parts engaging in abutments posts. We can look that up. JOMI 2019. So let's look it up. Norman tells us that seems to be literature, but we will check.
Team Düsseldorf, bring it up tomorrow.
Yeah, they'll bring it up. Peter, with this, I think we managed all questions. We are already ahead of time, but this was worth it. It was so nice. I think we also answered the Instagram post of Stefano, right? You already answered them in your lectures, all your key factors. I want to tell the people to register to our annual congress in Lisbon. Please also push abstracts. I guess the team Düsseldorf will also push abstracts there, and we'll be there from a scientific perspective. With this, Petra, I can only thank you on behalf of the EAO, but also on behalf of all the participants. They applaud you all. You can read the chat later. It was amazing. It was a great pleasure. You did a great job. With this, I say thank you from all around the world. Also on behalf of the board of the EAO, it was a pleasure hosting this session. And with this, I say good night all around the world. Ciao, ciao. See you all around. Ciao.
Thank you, Stefan. Thank you to everybody. See you soon.
Ciao.
Bye bye.